Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I'd like to talk to you about one of the most common procedures I perform in the Pediatric Emergency Department, suturing. Suturing is a procedure I particularly like because it gives me the opportunity to be the definitive care for a child and hopefully do the right thing. There are several rules I use for that procedure and very specific anticipatory guidance that I give parents at the end of it. I encourage you to listen to episode 6 where I talk about some important rules regarding procedures. So when I see a child that needs to be sutured after he or she sustained a laceration, I first make sure the parents understand what I think is the most important point. We are mostly here to prevent infection. So I always explain to parents that when the skin is compromised, especially in the feet or any other, quote, dirty area, the risk of infection is fairly great. And the most important job of the pediatric emergency physician is to make sure we do our best to prevent infection. Now, the most important studied method to prevent infection is irrigation. As the phrase goes, the solution to pollution is dilution. So I first make sure I tell the parents that suturing is important, but it's really a cosmetic issue. As a PEM physician, I'm mostly here to prevent infection. Now, irrigating the wound and irrigating it well to prevent infection has to be done in a certain way. It needs to be pressure irrigation with whatever solution you have. Pressure irrigation hurts, and therefore numbing is the first order of business. I personally find that LET, lidocaine, epinephrine, tetracaine gel or solution works very well, and for the most part, I rarely have to use local injection when I use LET on the wound. So after I apply LET for a good 20, 30, 40 minutes, as I said, first order of business is irrigation. To my understanding, the solution you actually use to irrigate is not particularly important. What's important is pressure irrigation. So again, numb the wound first, use a syringe. I personally use saline and betadine. It makes sense to me that betadine, which is an anti-infective solution, would be better than saline or tap water, which again, there's no evidence for it, but betadine is always available, very harmless. So I usually put it in some saline, dilute it to about 10% solution, and use that to irrigate. But again, as we said, pressure irrigation. Put some in the syringe and squirt it over the wound. And I usually use a fairly extensive amount of solution, again, simply because, as far as I'm concerned, my most important role today is to prevent infection. Again, that hurts, so make sure you numb the wound first. The next thing is to figure out the suture material, keeping in mind that one of the most important rules I use for procedures. Always use absorbable suture. I think those exist and they exist for a reason. I see no reason to put the child through another procedure that may be anxiety-provoking, removing the sutures, I mean. I personally always use absorbable suture with very few exceptions. If there's a high tension, if there's a very big gap, etc. I encourage you to look at UpToDate or other resources and understand the different type of absorbable sutures and their use. Nothing there needs to be memorized, but it's important to know that different absorbable sutures have different properties and should be used for different areas of the body, etc. For the most part, you can always look it up. It's just important to know that those differences exist. Now, before I actually suture, I advise you to always think about rule number 21. If you don't recognize the anatomy, it's time to call for a consult. Every once in a while, a patient comes to the pediatric emergency department with a very big wound or a very deep wound or a wound in an area when there are other structures involved. My classic example is a wound in the eye that is somewhat close to the tear duct and the medial canthus. That area has a lot of structures that I, as a non-ophthalmologist, do not want to cause harm to, so I prefer to use those for the specialists. So remember rule number 21, if you don't recognize the anatomy, it's time to call for a consult. Now, as far as the suturing technique, remember rule number 20, do it the right way, the same way, every time. There are many ways to create a square knot, which is probably the most important part of suturing, so it doesn't open. Whichever one works for you, so be it. If you have a certain method that you use to create a square knot and it works for you, go ahead and use that every time. Before you start your procedure, I advise you to think about rule number 26. When doing a procedure, the whole cart comes in the room. I can't tell you how many times I started my procedure and all of a sudden needed more supplies. I'm already having sterile gloves and a sterile field. It doesn't look particularly professional when you go in and out of the room and the parents look at you. I think there's nothing to lose by bringing the whole cart, and if you don't need all of the supplies, so be it. Teaching my technique for suturing is essentially impossible over a podcast, since this is not a video lesson. However, again, fairly simple technique. As long as you use a square knot and follow just a few simple steps, you're all set. Once I'm done suturing, this is what I tell parents as my anticipatory guidance. If you have listened in the past to PEM Rules, you may remember episode 22 from September of 2021 with my newborn talk to parents. This is my suture talk to parents, or how to prevent scarring and how to manage the wound at home. So the first thing I tell mom and dad, or the person who's taking care of the child, that we did everything we could today to prevent infection. We irrigated the wound extensively, maybe I even put some topical antibiotic, but please pay attention in the next few days if the area becomes red, swollen, more painful as opposed to less painful, and of course if there's drainage from the wound, that means it may have gotten infected, and I think you should probably come to the pediatric emergency department to see us. Since I always use absorbable suture, the next thing I tell the parents is that those sutures should absorb, but unfortunately sometimes they fail to do so. Please pay attention. In 7 to 10 days, if the sutures did not absorb, come to the pediatric emergency department so we can take them out like regular sutures. You can also go to your primary care if they're comfortable doing it, but the point is that if the suture linger, they can cause worse scarring. Essentially, those are foreign bodies and they have to come out if they fail to dissolve. Make sure you tell them that possibility unfortunately is still there, and if they fail to dissolve, they should come out like regular sutures. At this point, many parents ask me about how to prevent or minimize the scar. Here is what I learned from the pediatric plastic surgeons in Pittsburgh where I did my fellowship. So scarring is apparently very genetic. Some of us have great skin and develop very little scar. Some of us unfortunately develop keloids from a very minimal trauma. So what you and I as physicians or providers do for scarring is actually fairly minimal. The technique we use is almost always the same. The suture material is almost always the same. It's really about the patient's genetic. I make sure the parents know that. Not a whole lot we can do to begin with. However, as far as what I tell parents about scarring, here's what I learned from pediatric plastic surgery in Pittsburgh again, and this is what I tell them. So beside the fact that scarring is very genetic, there are some things you as a parent or a provider can do for your child in order to prevent scarring or bad scarring. Scarring is a very long process that takes about a year to form. So for the next year, mom and dad, this scar is going to be very sun sensitive, which means if little Johnny gets out and gets a suntan, the scar is going to be darker than the rest of the skin, and that's an ugly scar. So if this is a laceration on the face, I highly recommend little Johnny wears a hat for the next year, because again, we don't want this area to get a suntan. It's going to be darker and, quote, uglier. The other thing that prevents scarring is moisturizing. So keeping the area moisturized is very important for the health of the skin and the appearance of the scar. Lastly, massaging the area or rubbing the scar breaks the scar and makes it look better. So here's what I recommend mom and dad that you do for the next year if you can keep up. Every morning when little Johnny gets up, put a little bit of sunscreen on that scar and rub the area. The sunscreen keeps it moisturized, keeps it protected from the sun, and the massaging of the area breaks the scar. Do the same thing in the evening with some kind of moisturizer. Doesn't really matter. Again, you don't need sunscreen before you go to bed, but some kind of moisturizer, and apply pressure and massage to the skin. If you can keep that for a year, I highly recommend you do that. You can easily incorporate that into the brushing teeth routine. Every morning, you brush your teeth, put some sunscreen, give it a little massage, and go about your day. Every night, before little Johnny goes to bed, put some moisturizer, give it a little massage, and go ahead and go to bed. And if you can keep that for a year, that will minimize the scar. I also make sure the parents know that if the scar ends up being unattractive or too big or too disruptive for them, there's always a way to revise the scar with the plastic surgeon later on. But make sure the parents know, again, scarring is a very long process and it takes about a year to develop the definitive look of the scar. I also make sure the parents do none of that until the sutures either come out or dissolve by themselves. So for the first week or 10 days, do none of the above until the suture either dissolve or come out. Lastly, the last rule I apply for the encounter is document what you said, not only what you did. So if you took the few minutes to talk to the parents about scarring, preventing infection, what to come back for, what to watch for, etc., make sure you document all of that. I have a little macro or a shortcut in my electronic medical record where I basically place all that information. Something to the extent of discuss with mom and dad signs and symptoms of infection that should alert medical attention and return to the ER, and something like discuss with mom and dad ways to prevent scarring by keeping the area moisturized, etc. Again, if you did what you did, make sure you give yourself the credit. Not just the credit for what you did, but also the credit for what you've told the parents. And that is it for today, guys. That's a little bit about my talk to parents about suturing. Again, I can't show you my suturing technique since this is an audio podcast. However, this is what I tell parents, this is how I do it, and this is what I make sure I document. If you have any suggestions or if you use different anticipatory guidance for your talk, I'd love to hear it. So you can contact PEM Rules, submit any feedback through my website, and I'd love to talk about it in future podcasts. As an outro for today, this is a little slap riff I like to play on the bass. Not easy, takes a long time to practice this technique, worth every minute. Hope you like it.